اوكي الشاشة واضحة يا دكتور.
أهلا حبيبي، كيف أنت؟
يلا, you see it now? Is it clear, Khalid?
أي كلير دكتور، يمكن تبدأ.
Okay. إذا بتتذكروا من جمعتين بلشت بالبيناين تيومرز وحكيت عن الأوستيوما وجينا وصلنا للأوستيوبلاستوما، بس بدي أعطيكم ريزيومي عن الأوستيوما. الأوستيوما نعرف إنه هي أقل من 1.5 centimeters in diameter. It's a sclerotic lesion, clearly bounded at its boundaries. And in the center you have a nidus. وحكينا عن cyclooxygenase حكينا عن البروستوغلاندين يلي موجودين بالنيدس مع النيرف فايبرز وهولي بيعطوا الوجع. وحكينا عن pain occurring mainly at night and during the day, of course, and it's responding to non-steroidal anti-inflammatory drugs or aspirin. Halla, we come to a new set of tumors which are related to osteoma. Okay, Halla, I will come to it. Hey, osteoblastoma الباثولوجي تبعها زيت الشيء تمام مثل الباثولوجي تبع الاوستيوما. But most of these lesions occur in the spine. It is larger than an osteoma, meaning that osteoblastomas are more than 1.5 centimeters in diameter. Another difference is that they don't have so much pain. They have a dull ache. While in osteoma, the pain is severe and it occurs mainly at night. It wakes up the patient from sleep. This does not, osteoblastoma does not wake up the patient from sleep. They have a dull ache. And another difference is that osteoma is self-limiting and it involutes. After 3 years, it might disappear. But osteoblastomas don't. They progress, and there have been a few cases of osteoblastoma that have metastasized to the lung. So you have to keep this in mind. Another point is that osteoblastoma might be associated with an aneurysmal bone cyst. So keep this also in mind. The sites of involvement are mainly the spine, but it can occur in the metaphysis of long bones. And it is not common. It's a rare tumor. Osteoma is far more common. So let's go into it. So osteoblastomas are rare, aggressive, benign osteoblastic tumors. The male to female ratio is 2:1, and likewise in osteoma. Osteoblastomas are much less common than osteomas. The vast majority of affected patients are between 10 and 30 years of age. The etiology is unknown. This is an osteoblastoma occurring in the pedicle of a vertebra. The pedicle is completely enlarged. That's why we say that at times it is accompanied by an aneurysmal bone cyst. Another point is that osteoblastomas, when they occur in the pedicle, they may extend anteriorly and involve the vertebral body. At times, if you want to resect the tumor, which you should, you can resect the whole pedicle. But if it involves the vertebral body, then you have to do a VCR and do a much larger surgery than what you're doing. This is the pathology of an osteoblastoma, which shows interlacing trabeculae. These are the interlacing trabeculae. Okay, this is surrounded by fibrovascular connective tissue. This tumor is quite vascular. And if you look at the osteoblast on larger views, which is on the right side, you see normal, regular osteoblasts, not aggressive. You don't see very often mitosis, as you would see within osteogenic sarcoma. Also, you might see occasional giant cell tumors, giant cells, which is seen over here, giant cells. Okay, so keep this in mind. There is rimming of the osteoid, the trabeculae, with osteoblast. You see fibrovascular tissue, and you see that the osteoblasts are not very aggressive. They are not hyperchromatic. You don't see multiple sizes. They're all nearly the same size. We know it occurs more in males, and it can occur in many parts of the body, but mainly in the spine. In 40% of osteoblastomas involve the spine. This is an osteoblastoma of the proximal end of the humerus. You see it's quite large. It's more than 1.5 centimeters. It's more than 1.5 centimeters in diameter. Okay, so this is the lesion. There is a zone of sclerosis. Okay, and that's the difference between it and an osteoma, which is much smaller. But both have a zone of rarefaction in the center. This is an osteoblastoma involving the posterior arch of the vertebra. You notice that it starts here, but it can produce and extend distally through the pedicle into the vertebral body. You should remove these lesions. In around 1%, you can have metastasis. This is a very rare tumor, by the way. This is another rather more aggressive tumor, but again, you see the trabecula, which is pink, and it is bounded by normal osteoblasts. The difference between it and an osteosarcoma is that the osteoblasts are aggressive in osteosarcoma. It is slowly progressive, dull, and provides aching pain for a long period that is less severe than that from an osteoma. Night pain is not typical, as I mentioned before, while osteoma, the pain occurs mainly at night. Neurologic symptoms can occur. Why? Because it's quite large, especially when it occurs in the spine, and this is the most common location for it to occur in the posterior elements. We mentioned this in the previous lecture, that osteostomas occur in the diaphysis, osteoblastomas in the posterior elements, and metastasis of bone. The size is 5 to 15 millimeters for osteoblastoma, and it's more than 1.5 centimeters for osteoblastoma. It's self-limited for osteoblastoma and progressive for osteoblastoma. The pain is worse at night for osteoblastoma, and for osteoblastoma, it is less, and they have a dull ache. Other locations include the diaphysis of the metaphysis of long bones. This is rare, but we've seen osteoblastomas in the mandible. You have, by MRI, related swelling, you have muscle atrophy, you have a patient who has a limp, and the lesion can be quite large at times. Osteoblastomas may be associated with oncogenic osteomalacia. What about the imaging? We said it's a radiolucent lesion, 2 to 10 centimeters in size, with occasional intralesional densities. Cortically, it's based more often than in the medullary region. It is expansile with extension into the surrounding soft tissues. And you have a rim of reactive bone around the lesion. 25% of the lesions have an extremely aggressive appearance and are mistaken for a malignancy. Radiographic differential diagnosis is, as I repeatedly mentioned, osteosarcoma, primary aneurysmal bone cyst, and osteoid osteoma, and last but not the least, osteomyelitis, especially subacute osteomyelitis. In the X-ray or the slide or the CT scan or the transverse scan that I have shown below is tridimensional. And this is very important because it gives us the boundaries of the lesion, especially when we want to resect the tumor in the spine. The histology is similar to an osteoblastoma, as I bored you with it, but there is increased giant cells. You have irregular seams of osteoid separated by loose fibrovascular stroma. The osteoid is rimmed by prominent osteoblasts that are occasionally large and epithelioid, and it's most commonly there is a sharp demarcation from the surrounding bone. In other words, it tells you more or less that it is towards the benign side and not very aggressive. 10 to 40%, I repeatedly tell you that 10 to 40% are associated with secondary aneurysmal bone cell cyst formation. You have to keep this in mind because there are other lesions which are associated with ABC formation, like giant cell tumors, like fibrosarcomas, like osteoblastomas, chondroblastomas. All these could be associated with an aneurysmal bone cyst. Speaking of aneurysmal bone cyst, I had recently an osteosarcoma involving the vertebral body of T12. The intervention radiologist did a core biopsy. He took it from one particular region, and the report was an aneurysmal bone cyst, and the patient was treated in a very different way than being an osteosarcoma. So you have to be very careful. Numerous mitotic figures may be present, but they are not atypical. It is important to differentiate osteoblastoma from osteosarcoma, although giant cell tumor and aneurysmal bone cysts are also similar in appearance. This is what I tried to send you the message. The treatment. Osteoblastoma is not self-limited and requires surgical treatment. In most cases, curettage and bone grafting is adequate to achieve local control. Nerve roots should be maintained when treating spinal lesions. Occasionally, en bloc, as I mentioned, resection is required for lesions in the spine when the lesion extends through the pedicle into the vertebral body. Another tumor, which is benign, is parosteal osteoma. It's a rare, self-limited deposition of reactive bone on the surface of the cortex. Adults are most commonly involved between 30 and 40 years, and the etiology is not known. Some say it could be related to trauma, and this subperiosteal hematoma changes into bone. The clinical history is associated with a long history of gradual swelling or dull pain. Occasionally, incidental radiographic findings are present. Classically, osteomas are found in the craniofacial bones. ما بيصير إلا ما شايفين حدا عنده مثل دعبولي براسه أو على وجهه, and it turns out to be a parosteal osteoma. It has rare presentations in other parts of the skeleton, namely the tibia and femur and pelvis and vertebrae. Multiple osteomas are associated with Gardner's syndrome. We all should be well acquainted with Gardner's syndrome. It is autosomal dominant, which also includes colonic polyps, fibromatosis, cutaneous lesions, and subcutaneous lesions. Why do we say Gardner's syndrome is important? Because patients who have this have a higher incidence of bone tumors. For instance, osteosarcoma would be one of the cases. This is an parosteal osteoma of the forefront of the skull. Okay, look at the skull. Look at the frontal portion. You see these hard masses. Below, you see parosteal osteomas of the mandible. So you have to keep this in mind. Please keep this in mind. You cannot miss a parosteal osteoma. And one of the questions we used to put in the past in the board exam was showing patients with these lesions, and we would try to get a good answer. What about the imaging apparent? They have a uniform radiodense lesion attached to the bone cortex. But I would like to bring this to your mind. Look at the X-ray on the upper right-hand side. You see that the medullary cavity is not continuous with the medullary cavity of the main bone or the parent bone. You have to realize this, and this differentiates it from an osteochondroma. It has a broad base. It ranges from 1 to 8 centimeters in size. It's well defined with a smooth lobulated borders. There is no cortical, remember this, no cortical or medullary invasion. And this is well demonstrated on the CT scan below. And the differential diagnosis should be from a parosteal osteosarcoma, a healed stress fracture, and an osteoid osteoma. The pathology, look at the upper right-hand side of this slide. You can see that the histologic appearance is of mature hypocellular lamella bone with intact haversian systems, and there is no atypical cells that are present. The treatment, of course, is non-surgical and is preferred to any form of treatment. But you have to follow up your patient. You have to make sure it's not a parosteal osteosarcoma. You have to make sure that the lesion is not progressive. These are examples of these tumors, the parosteal osteoma, to differentiate it from an osteochondroma. It is very clear. You see that there is a clear zone. There's no connection with the medullary cavity. You see the other side of the lesion is in line with the cortex. Look at this lesion. These are parosteal osteomas, and you look at the lesion, if excised, you see it consists mainly of lamella bone. What about a bone island? Enostosis. What about it? Look at this. This is an enostosis, a bone island. Why did I say this? Look at the periphery of the lesion. It is serrated. This is typical. Another point, look at this lesion. It is a benign lesion. It has a clear demarcation between the host and the lesion. The lesion is not. نعم. مين قال؟ مين حكي؟ The lesion.
استمر دكتور.
It's okay. The lesion is completely demarcated from normal bone. Look at the calcaneum. I've seen quite a few in the calcaneum. Look at the serrated. يعني مثل البيبيس طالعين منها. This tells you it is an enostosis, a bone island. These are benign lesions. They are usually small, but occasionally they can be large, and it's a deposit of dense, compact bone within the medullary cavity. Don't forget this. And bone islands occur frequently in adults. I've seen quite a number in my experience, but their true incidence is really unknown because they are discovered by chance. It is possibly caused due to an arrested resorption of mature bone during endochondral ossification. What about the clinical presentation? This non-tumorous lesion is asymptomatic and found incidentally. Any bone can be involved, but the pelvis and femur are most common. Another condition that can be confused with it is a condition of dysplasia. Sacral khat. Osteopoikilosis is a hereditary syndrome that manifests as hundreds of bone islands. And many times when it occurs around the joint, we confuse it with synovial chondromatosis. So keep this in mind. I tell this to the residents always. Beware, don't call all lesions where you see multiple ossifications around the joint synovial chondromatosis. You should think of osteopoikilosis. What about the radiologic appearance that I have repeatedly told you? But you should listen to these repetitions. Why? Because this is the only way you can memorize these tumors. طلعوا بالX-ray of the proximal humerus on the right-hand side. Look at the lesion. It is localized. Look at the periphery. It is serrated. There are multiple pins coming out. This would tell you immediately that this is an inostosis. Occasionally, radiating spicules of bone around the lesion that blend with the surrounding medullary cavity are present, and approximately 1/3 of the lesions show increased activity on bone scan. This is another lesion. طلعوا عليها. It's localized. مش يعني بس this patient has an osteosarcoma. لا, you have to evaluate the patient. You have to follow up the patient. Especially also if you do a scanogram and you see that there's increased uptake. It could be a malignant tumor. Don't forget that these bone islands can show activity on bone scans. There is no surrounding bone reaction or edema on T2 weighted MRI images. They have a low intensity on T1 and T2 weighted MRI. You don't see any edemas or reaction. Radiographic differential diagnosis includes well-differentiated osteosarcoma, osteoblastic metastasis, and bone infarct. Keep this in mind, a bone infarct. Keep it in mind, osteoblastic metastasis, and well-differentiated osteosarcoma. هيدا إذا حاطينكم بالفحص حاطينكم هيك, and tell us, give us a differential diagnosis. And this is what we expect. This is the pathology on these lesions. Bone islands appear histologically as cortical bone with a well-defined lamellar structure and eversion systems. The border between the lesion and the surrounding medullary bone shows no endochondral ossification. Treatment? No treatment is required, but follow-up radiographs should be taken if there is any question about the diagnosis. Solitary enchondroma. We're moving into cartilaginous lesions. If you look at this X-ray, I'm going to give you a general idea, and then we'll go to it in detail. If you look at this proximal femur, you look at a zone of calcification. You see that it looks like well marginated calcification, which we call the popcorn appearance. If we see it's not like this and irregularly dispersed, then we say it looks more aggressive. We look at the cortices. We see if the cortex is broken or if they're scalloping, but you need to see it more clearly on a CT scan. When you get a calcified matrix like this, with some rarefaction around it, arising mainly in the metaphysis of bone, and if you take a specimen and analyze it, and you see a bluish tinge, a bluish matrix on staining with hematoxylin and eosin, you have to think of a cartilaginous lesion. But I'll tell you, you have to distinguish between a malignant and a benign lesion. Now we'll go into detail. Enchondromas are benign tumors. They are comprised of major hyaline cartilage and located in the medullary cavity. Don't forget it. Osteodystrophies mainly in the cortical bone. Osteoblastomas also. Parosteal osteomas likewise. The ones which are similar are bone islands, enostosis, which could occur in the medullary cavity. Enchondromas can occur at all ages, and it's most common in patients between 20 and 50 years. The incidence is unclear because most lesions are found incidentally. Enchondromas are thought to be related to incomplete endochondral ossification, where fragments of epiphyseal cartilage displace into the metaphysis during skeletal growth. They are more common in females than males. It can occur in any location. We don't like to see them in the pelvis and the proximal aspect of the humerus. Why? Because the more proximal they are, the more chances they could be aggressive and be chondrosarcomas. So one should keep this in mind. The most common site of an enchondroma is in the small bones of the hands. You can see the zones of calcification. You can see the cortex. And in this X-ray, you see an erosion of the cortex with calcification. Now, would you say this is malignant? Well, we know that these do occur in the hands and tend to be apparently aggressive, but usually they are not. If you get the fracture over here, you should not rush in and correct and bone graft. Wait until the fracture heals and then do whatever is needed for the patient. You see that there is a chondroid matrix. You see that there are cartilage cells. Occasionally, there are 2 cells within the lacunae. And you see that these cells look apparently benign. They're not very aggressive. You don't see various sizes. And let me tell you at this stage, it's very, very difficult at times to tell the difference between an enchondroma and an early stage of chondrosarcoma. It can be quite difficult. But we depend on several findings. First of all, we depend if the patient is having pain. That's number 1. Number 2, we depend if the cortex is eroded. Number 3, we depend on the increased uptake on technetium scans. These three things, if present, we go more for a low-grade chondrosarcoma. This is the metaphysis of a lesion, which is an enchondroma. You should be able to distinguish it from a scar or avascular necrosis of a zone in the metaphysis. Most enchondromas are asymptomatic and are noted incidentally when radiographs are taken for other reasons. Lesions in the small bones of the hands and feet can be painful, especially after a pathologic fracture. When a patient presents with enchondroma and pain in the adjacent joint, the pain often has a cause that is unrelated to the tumor. And if the patient has pain and the radiographic appearance is suspicious, low-grade chondrosarcoma must be considered. So keep these in mind. Half of all endochondral or enchondromas occur in the small tubular bones, with the vast majority in the hands. I spoke to you about this. Enchondromas are the most common bone tumors in the hand. That's one question that we like to ask. Where does enchondromas occur most? And we put the hand plus other regions, and you should answer as hand. Other common locations include the metaphysis or the aphysis of long bones. The proximal humerus is quite common. The distal femur tibia. Enchondromas are rare in the spine and pelvis, but we don't like them so much. The ones that I identified in the pelvis were more or less malignant. By the way, am I clear so far? Am I clear يا جماعة?
واضح جدا دكتور.
Am I clear?
Yes, it is clear.
Okay. Best if there's any questions, try and stop me. Okay?
Okay.
طلع بالphotos of the hand. You see the deformities that enchondromas cause. You see the way it appears with a central lesion, with calcification within the lesion. If you look at the lateral view, you have to differentiate between it and a scar or an avascular zone over here, avascular necrosis. If you have a fracture of the phalanges, don't operate. Wait until it heals and then do your correctement or do whatever you want, but don't do it immediately. Enchondromas are classified by Enneking as inactive or latent bone lesions. And I would like to mention that there are latent, there are aggressive as number 3, and active. These are divided according to the Arabic numerals. 1, inactive or latent. 2, active. And 3, aggressive, which will be giant cell tumors. The incidence of malignant transformation for a single enchondroma is only 1%. Keep this in mind. بالماضي كنا نفكر إنه أكثر, but this is only less than 1%. A dedifferentiated chondrosarcoma rarely develops from an enchondroma. But don't forget that the more proximal lesions are towards we don't like and more dangerous for transformation. Enchondromas begin as well defined lucent central medullary lesions. Okay? Central medullary lesions that calcify over time, and they appear more diaphyseal as the long bone grows. What else does it? Unicameral bone cysts, which we will be talking about. The classic radiographic appearance involves rings and stippled calcifications within the lesion. Lesions can be from 1 to 10 centimeters in size. And when in the medullary cavity, which is usually the case, they erode the cortex from inside, especially if there is suspiciousness of it changing to a chondrosarcoma or malignant lesion. These show you the various lesions, the ground substance or the matrix, which is bluish on hematoxin and eosin stains. You see the nucleus. You see they are not very aggressive. Cortical thickening or destruction, as I have repeatedly said, suggests a chondrosarcoma. A radiographic differential diagnosis includes bone infarct that I have repeatedly mentioned and low-grade chondrosarcoma. The radiographic appearance is more important than the pathologic appearance, and this is very true in differentiating an enchondroma from a low-grade chondrosarcoma. Enchondromas frequently have increased uptake on bone plants that I have mentioned about. Don't forget this. And when they have a lot of uptake, plus erosion, plus pain, think of a low-grade chondrosarcoma. MRI is not necessary for the diagnosis, but shows the lesion as lobular and bright on T2 weighted images with no bone marrow edema or preosteal reaction. The gross appearance is of blue-gray lobulated hyaline cartilage with a variable amount of calcification throughout the tumor. If you realize I am doing quite a number of repetitions, by repeating and by listening, you will remember the tumor. The low-power histologic appearance is of mature hyaline cartilage lobules separated by normal marrow, which is key to differentiating an enchondroma from a chondrosarcoma. Endochondral ossification encases the cartilage lobules with lamella bone. So you have cartilaginous tumor surrounded by bone. If it does, starts in a child with growth. It is usually central. This differentiates an enchondroma from an osteochondroma. Lesions in the small tubular bones and proximal fibula are more hypercellular than lesions in other locations. Enchondromas in long bones have abundant extracellular matrix, but no myxoid component. The cells are bland with uniform dark stained nuclei. Okay? They have no pleomorphism, as I mentioned, neither necrosis, mitosis, or multinucleated cells. Look at this. Never forget this. The nuclei are innocent. It's true that they are a bit hyperchromatic, but there is no mitosis. You see in the lacunae single cells, so you have to keep this in mind. Treatment: asymptomatic lesions require no treatment, but should be followed with serial radiographs to ensure inactivity. Rarely, when pain due to other causes is excluded, symptomatic enchondromas can be treated with curettage and bone grafting. So pain could be the judge. You have to rule out other causes of pain, and if the pain is not found to be related to any of them, then you are justified to operate, curette, and bone graft. And of course, send to a good pathologist. Make sure that you get specimens from all parts of the lesion. Pathologic fractures through enchondromas in small tubular bones should be allowed to heal. I've told you this repeatedly prior to curettage and bone graft. If radiographs are suspicious for a chondrosarcoma, of course, then surgery is necessary. A needle biopsy is not reliable to differentiate enchondromas from low-grade chondrosarcomas and should be used only if confirmation of tissue type is needed. Now, Olliers disease. I want to ask, are there any questions now? Are there any questions? Huh? No questions? No one has a question? Yes.
Dr. June, continue. Okay.
I'll continue.
Yeah.
طيب طلعوا بالسلايد هاي. هالسلايد بتخوفنا. هالسلايد بتقلنا انه الواحد عنده multiple enchondromas. تطلعوا بهالسلايد بتلاقوا في zones of phlebol or calcifications. These are vessels. And when they have this, they have Maffucci syndrome. We will discuss Olliers followed by Maffucci. This is a patient, as I told you, enchondromas are more common in females. This patient has Olliers. Look at this patient. Look at the facial view. You see that the right leg is bowed and shorter than the other leg. You see that the hand on the right side is more involved than the left. The leg on the right side is more involved than the left. This patient, when we take x-rays now on her, will find out that she has Olliers disease. Olliers disease is multiple enchondromatosis on one side. It can have other lesions on the other side, but it is definitely much less than the other. Okay, look at this photo. Never forget it, please, because by looking at it, you will be able to answer this question. It's unilateral, there is deformity, and when you looked at the x-rays before, if you see calcifications, you have to think of Maffucci syndrome. The related conditions are between Olliers and Maffucci. Olliers disease is characterized by multiple enchondromas with a tendency toward unilateral involvement of the skeleton. I repeat, unilateral involvement of the skeleton. And it occurs as a result of sporadic inheritance. Multiple enchondromas are thought to indicate a skeletal dysplasia with failure of normal endochondral ossification throughout the metaphysis of the affected bones. Patients with multiple lesions have growth abnormalities causing shortening, as you saw in the photograph, and bowing deformities, as you've seen in the tibia, which was bowed. Maffucci syndrome involves multiple enchondromas plus soft tissue angiomas. It is the phleboliths that you have seen. Radiographically, the enchondromas have variable mineralization and often markedly expand the bone. The angiomas in Maffucci syndrome can be identified on radiographs due to phleboliths, small, round, calcified bodies. The histologic appearance of lesions in a patient with multiple enchondromas is similar to solitary lesions in small tubular bones, hypercellular with mild chondrocyte atipia. Patients with multiple enchondromas may require surgical correction of skeletal deformities at a young age. There is an increased risk of malignant transformation of an enchondroma to a low-grade chondrosarcoma in patients with Ollier's disease from 25 to 30%. إذا بتتذكروا قلت لكم الانchondroma when it's solitary, it's less than 1%. But with Ollier's disease, it rises to 25 to 30%. Patients with Maffucci syndrome have an increased risk of malignant transformation of an enchondroma from 23 to 100% to a low-grade chondrosarcoma, as well as high risk of developing fatal visceral malignancy. Patients with these syndromes need to be followed very closely over a long-term period because of the increased chance of malignancy. Next is periosteal chondroma. In my life experience, I've had 2 such lesions. If you see, it's a chondroma which appears subperiosteal. I've had 1 lesion in the clavicle and 1 in the humerus. It appears like it's a staucerized position, lesion, or an erosion of the cortex. And if you look at the pathology, you see it's cartilaginous ground substance of hyaline cartilage. Periosteal chondroma, it is a benign hyaline cartilage tumor located on the surface of bone. Periosteal chondromas occur in patients from 10 to 30 years of age. The etiology, these are rare lesions thought to arise from pluripotential cells deep in the periosteum that differentiate into chondroblasts instead of osteoblasts. I'll tell you, this is also involved when we differentiate between a parosteal osteosarcoma and a periosteal osteosarcoma. You have to, when I come to them, we will talk about. Patients present with pain or sometimes lesions are found incidentally in asymptomatic patients. Any bone can be involved, but the proximal humerus, the femur, and the small bones of the hand are the most common locations. These lesions can grow slowly as the patients reach skeletal maturity, but have no malignant potential. The imaging appearance includes the classic appearance, which is well-defined surface lesion that I showed you in the previous x-rays that creates a saucerized defect in the underlying cortex. The lesion ranges from 1 to 5 centimeters in size and is metaphyseal or diaphyseal. There is a rim of sclerosis in the underlying bone. Look at this lesion. Look at the sclerosis from that. It arises from the deeper zones of the periosteum, which instead of forming osteoblasts, they form chondroblasts, and they form this periosteal chondroma. Look at the hyaline cartilage as the matrix, and you can see the individual chondroblasts. The edges of the lesion often have a mature buttress of bone. The amount of calcification is variable, and soft tissue swelling may be present because of the surface location. The radiographic differential diagnosis includes periosteal chondrosarcoma. I would like to correct myself and say periosteal chondrosarcoma and periosteal osteosarcoma. And of course, you should not forget about parosteal osteosarcoma. So these are 3 points. Pathology. The low power appearance is of well-circumscribed hyaline cartilage lobules. The histologic appearance is similar to that of enchondroma, with mild increased cellularity, binucleated cells, and occasional mild pleomorphism. Treatment. No treatment is needed for asymptomatic patients. Symptomatic patients are treated with excision with a marginal margin, and local recurrence is rare. This shows you the lesions and the pathologic specimens. This is another lesion occurring at the proximal end of the humerus, another lesion at the distal end of the femur. It gives you a saucerized picture. You see that there's a zone of sclerosis at the bottom of the lesion. It is a benign lesion. The indications for surgery is only when you have pain and you're not sure of your diagnosis. This is another lesion. Osteochondroma. Osteochondroma is a benign cartilage tumor arising from the surface of bone. Osteochondromas are the most common benign bone tumors. The true incidence of osteochondromas is unknown because most lesions are asymptomatic. Most lesions are identified in the first 2 decades of life. A bit about the etiology. Osteochondromas are called hamartomatous proliferations of bone and cartilage. They are thought to arise from trapped gross plate cartilage that herniates through the cortex and grows via endochondral ossification beneath the periosteum. A defect in the perichondral node of Ranvier. The perichondral node of Ranvier is the surrounding cartilage around the physis, and it holds the secondary epiphyseal ossification center to the primary in a much more firmer way, together with the fibrous tissue around. This is what I mean by perichondrial node of Ranvier. Any question? Any question? No question. Very clear. Okay, thank you. The clinical presentation. Most lesions are solitary and asymptomatic. Most are less than 3 centimeters in size, but they can be as large as 15 centimeters. Depending on the size and the location, patients can have pain. For instance, this stalk of an osteochondroma can press on a nerve. It can press on a tendon and cause tendinitis. It can even press on a vessel and lead to an aneurysm lesion. So you have to pay attention to these lesions. From an inflamed overlying bursa, fracture of the stalk, I've seen a few cases, or nerve compression. Please don't forget these fine statements. When close to the skin surface, they are firm, immobile masses. When we say a mass in a muscle, is it mobile or not? We like to see whether it's attached to bone. Osteochondromas continue to grow until the patient reaches skeletal maturity. The lesions most commonly occur around the knee, the distal femur, and the proximal tibia, the proximal humerus and pelvis. Spinal lesions do occur. I've seen an osteochondroma of the transverse process. I've seen it in the region pressing on the nerves. I had to go ahead and operate and remove it together with the transverse process. Now, if you look at these two x-rays, you see on the right-hand side or the left-hand side when you're looking at the screen, you see that you have a stalk, and this stalk is broken. And look at the medullary cavity. It's continuous with the medullary cavity of the parent bone. Look at the sclerosis, the cortical area. You see that it is continuous. This differentiates this from other lesions on the surface of bone. It can be cauliflower.
الجهاز تاع الضغط عرفتيه؟ ما خليه يحتاج
Any questions؟ في شيء أسئلة يا جماعة؟
ما في أسئلة، يمكن في حد دخل على الخطوة.
طيب, let's look at a osteochondroma. If you look at the end, it may be pedunculated, it may be cauliflower, and it can be serous. When you have an osteochondroma which is wide and serous, you should tell your students that this has a chance to malignant transformation more than one with the stalk. Why? Because you have a large surface area and a larger cap. The chances to change are more in these when you have a pedunculated one. Let's look at these lesions. You can see each one. Look at the medullary cavity. It is continuous throughout these lesions. Okay, you have to pay attention to this. Look at this lesion. This is a pedunculated. It has a stalk. It is continuous. This compressor, you see, this is in the region of the adductor canal, and the vessel is mainly over here. This can produce pressure on the vessel. This is very rare, but you can have an aneurysm. or else the stalk is very thin. From any trauma, it can break. So you have to think of these. You have to use your head. Look at this. The osteochondroma is at the fibula, but on the medial aspect, it's growing and causing the tibia to have a deformity, an erosion. You can see it over here. Don't forget, you have to follow up these patients and see what happens. This is a what? Yeah, cauliflower, yeah, cereus. You see the distance is large. This surface area is more than a pedunculated area. So it has more of a chance to change to malignancy. But these are very rare. Don't forget this. Now, at this point, if you look, there's the physis. When you get such a patient with a lump, you have to treat the family. The family comes to you. This patient has a lump. He's suffering. What could it? Could it be a malignancy? They're worried. They're panicking. My advice is, if there are no significant symptoms, wait until the physis closes and then remove the lesion. Because in my experience, I've removed quite a few. Some I removed before the physis was closed to treat the family. The far majority recur with time. Why? Because the source that is producing cartilage is still present. Don't forget this. This is very important. Look at this. This is pedunculated. But look at, he has a fracture over here. He has a fracture of the stalk, and the patient presented with pain. Look at now, we come to the stalk, the cartilaginous gap. This is the gross area, and this is which is producing cartilage. And this stops producing growth or cartilage when the parent bone terminates growth. You have to keep this in mind. But if you have a growth following that termination of growth of this stalk, you have to worry about it. You should evaluate it. You should do MRIs, CT scans, see the thickness of this cartilage. We found that if this is more than 2 centimeters in thickness, we should worry in an adult of it being changing to either chondrosarcoma or osteosarcoma or whatever it is. This shows you the cartilage cells. When I say that there are 2 cartilage cells in the lacunae, this is the lacunae, and you see that there are 2 nuclei, 2 cartilage. Likewise, there can be very minimal mitosis. It's in a bluish discoloration, which is the matrix, the hyaline matrix that is present. So you have cartilage cells within the hyaline matrix. This shows you the growth center of this chondroma, osteochondroma, and of how it's growing. If this is more than 2 centimeters in thickness, you should worry. So, let's take osteochondroma and chondrosarcoma. What about the relation to parent bone? Continuity of the cortex and medullary cavity with the parent bone. Don't forget this. They have the same medullary cavity, but the cortex is continuous from either side. Chondrosarcoma is a gradual loss of continuity of the cortex. There is no continuation between the medullary cavity and the lesion. The external surface of the tumor is distinct and well demarcated, while chondrosarcoma is fuzzy and indistinct. The cartilaginous gap is best visualized on magnetic resonance imaging, and we like to see it less than 1 centimeter. If it's thicker than 2 centimeters, I wouldn't say 3 centimeters, you have to make sure that it's lobulated, and you will have to rule out chondrosarcoma. The matrix pattern, they have dens at the periphery with solid cortex. They have normal cancellous bone centrally. At the periphery in chondrosarcomas, in appearance with small areas of rarefaction, disorganized calcification, later blotchy areas of calcification within the center, tumor and streaky densities extending peripherally. Large soft tissue masses containing disorganized calcification, mitosis, you have to have hyperchromatism in chondrosarcoma. Another point, ما بيصير لما حدا منكم شايف subinguinal exostosis, which arises from beneath the nail in the distal finger or phalanx, and this is post-traumatic lesion and not a true osteochondroma. Patients can present with multiple lesions, multiple hereditary exostosis, and the risk of malignant degeneration of a solitary osteochondroma to a chondrosarcoma is less than 1%, as I mentioned. Rarely, a dedifferentiated chondrosarcoma can develop from a solitary osteochondroma. يعني قليل كتير solitary changes to malignant chondrosarcomas. I'll tell you, when it comes to multiple lesions, then the story changes. Osteochondromas can be sessile, pedunculated on the bony surface. There is a higher risk of malignant degeneration in sessile lesions. Why? Because you have a flat surface, you have a broader area. Lesions arise near the growth plate and appear to become more diaphyseal with time. Pedunculated lesions grow away from the adjacent joint according to the line of pull of muscle. It grows away from the joint. Okay, you have to pay attention to this, and this is characteristic. The medullary cavity of the bone is continuous with the stalk of the lesion. And these show you each of what I have told you every time. لك طلع هون stalk. طلع on which direction is it growing? It's growing proximally. And this tells you it's an osteochondroma. The cortex of the underlying bone is continuous with the cortex of the stalk. The affected bony metaphysis is often flared or widened. The cartilage cap is usually radiolucent and involutes at skeletal maturity. It involutes, it shrinks as maturity arrives. If it enlarges and becomes thicker, then you should be aware that this could be changing to a chondrosarcoma. Metaplastic cartilage nodules can occur within a bursa over the cartilage cap. The radiographic differential diagnosis includes parosteal osteosarcoma and myositis ossificans. CT or MRI scans can better evaluate the cartilage cap and are useful when malignant degeneration is a concern. The gross appearance of pedunculated lesions is similar to a cauliflower with cancerous bone beneath the cartilage cap. Histologically, the cartilage cap consists of hyaline cartilage and is organized like a growth plate with maturation to bony trabeculae. There is a little defined perichondrium around the cartilage cap. Again, I'm showing you the same. The stalk consists of cortical and trabecular bone with spaces between the bone filled with marrow. The chondrocytes within the lesion are uniform without pleomorphism or multiple nuclei. Thick cartilage caps imply growth, but are not reliable indicators of malignant degeneration. For asymptomatic or minimally symptomatic patients who are still growing, non-surgical treatment is preferred. Please keep this in mind. Relative indications for surgical excision of an osteochondroma performed by excision of the base of the stalk, symptoms secondary to soft tissue inflammation, bursae, muscles, joint capsule, and tendons. Symptoms secondary to frequent traumatic injury, significant cosmetic deformity, symptoms secondary to nerve or vascular irritation, concern for malignant transformation. The perichondrium over the cartilage cap must be removed to decrease the likelihood of local recurrence. أوقات بلاقي إنه عندهم سيروس بشيلوا قسم منها بخلوا قسم الثاني. What is the purpose? You have to remove the full cartilage cap so as to be at ease that you have done what is necessary. Okay? Delaying surgical excision until skeletal maturity allows a higher chance of local control. Patients with osteochondromas extending into the popliteal fossa can have pseudoaneurysms and are subject to vascular injury during excision. Okay, I'll take a 2 minute, 3 minutes, 5 minutes break. خالد في مانع اخذ 5 minutes؟
دكتور جون خذ راحتك. اوكي تمام.
دقيقتين بس. ليك خالد بدك تعرف انه اليوم طويله. اليوم
أوكي.
طويله بدكم تحملوني.
لا اهم شيء تحملنا انت، ما احنا منفضل احنا قاعدين.
لا انا بقول عملها طويله. Let me be honest لان بدي خلص التوبكس. بدي شيلهم عن دربنا. اوكي.
ايوه افضل تمام.
اوكي. بس ان شاء الله يكونوا عم بيفهموني. ان شاء الله ليك عم بعيد وبعيد 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 لحتى يفوتوا على راسهم. انا زعلان اليوم انه اليوم ما في كتير حضور 17 مع انه this lecture I think it's the most important lecture. Multiple hereditary exostosis. I repeat, multiple hereditary exostosis. This is a skeletal dysplasia that is inherited with an autosomal dominant pattern. Patients may have up to 30 osteochondromas throughout the skeleton. The EXT1, the EXT2, and EXT3 are 3 genetic loci associated with this disorder. تذكروها لأن هي سؤال كمان بنحطه. Which tumor is associated with this? Which condition is associated with this? Mutations in these genes are found in most affected patients, and they are considered tumor suppressor genes. Clinically, the patients have skeletal deformities and short stature. The lesions are similar radiographically and histologically 2 solitary osteochondromas. Radiographs reveal primarily sessile lesions that may grow to a very large size. Metaphyseal widening is present in affected patients. Look at the patient. At the site of the lesions, you see that the metaphysis is widened. You see it's widened, the metaphysis. And you can see the lesions. The whole bone changes into shape. Likewise, in the tibia on the right-hand side, you see of how the lesion is apparent and changing the whole tibia in shape. These lesions appear as bumps. They can occur anywhere. If you look at the patient's hind, showing the popliteal region on the right side, you see the bump, you see the protrusion. You know what occurs over there, the peroneal nerve. This patient was having peroneal nerve irritation. If you go below and you look at the lesion on the left side, and if you take an X-ray at that level, you see that the lesion has changed the shape of the distal tibia. So you have to be very careful. Lesions can pressure on vessels. You can have aneurysms of the vessels. It can press on muscles and cause irritation. It can limit motion in some areas by coming in the way of the joint. This is more apparent. Look at the fibula. Look at the tibia, which is enlarging the metaphysis. Look at where the lesion is arising. It's multiple osteochondromas arising from multiple areas. They can be serous, they can be pedunculated, they can be cauliflower, and it can cause various deformities. Look at this lesion. This lesion. It's proximal. It is an aggressive lesion. And this patient turned out to have a dedifferentiated chondrosarcoma. So you have to pay attention to these lesions. This is another lesion occurring in the ulna, causing the radius to become deformed secondary to pressure of the lesion. This is another lesion causing pressure on the ulna and causing deformity. This is multiple osteochondromatosis, Dahlen's disease. And you can see it over here. You see the medullary cavity and the cavity of the stalk is the same. Look at over here, the cauliflower appearance. You have to think of this. You should worry when you see these lesions. This one, he has the lesion in the subungual area. They have growth plates, and these continue to grow. And if they grow after maturity and they don't arrest, then you should worry about them, because malignant transformation over here is higher than usual. Deformities occur due to disorganized endochondral ossification in the growth plate and may require surgical correction, especially in the paired bones, like I showed you, the radius and ulna, the tibia and fibula. The risk of malignant transformation is higher than a solitary osteochondroma, which is less than 1%, of where it goes up to 10%. In the most common location of a secondary chondrosarcoma is the pelvis. That's why I told you I don't like, and we don't detect these lesions. Why? Because there is much space in the pelvis. They can grow to large sizes before they begin to have symptoms. Usually the malignant tumors are low grade. Chondroblastoma. If you look at this lesion, you can say it's a lesion, it's occurring in the epiphyseal ossification center. You can see it by MRI, you can see it over here by a diagrammatic area. It is common to occur, chondroblastomas, which are cartilaginous tumors. They occur in the epiphyseal ossification and later extend into the metaphysis. It can occur in the proximal humerus and in the distal femur, proximal tibia, and it's quite common to occur in the rapid growing areas. So you can see in the pathology, giant cells, chondroblast. It's not very aggressive. So there are some hyperchromatic cells. We very rarely see any mitosis, but we see numerous giant cells. But what is characteristic? Look at this. This is a pebble appearance, or you can have a chicken wire appearance. I'm trying to see. A chicken wire بالعفص الجيش. Chondroblastoma is a rare benign bone tumor differentiated from giant cell tumor by the chondroid matrix. This is a lesion which occurs in children before the closure of the epiphysis, while giant cell tumors occur in the epiphysis once it's closed, and it can occur combined in the metaphysis and the epiphysis. The male to female ratio is 2:1. 80% of patients are younger than 25. Chondroblastoma has been categorized as a cartilage tumor due to its areas of chondroid matrix, but type 2 collagen is not expressed by the tumor cells. It is thought to arise from the cartilaginous epiphyseal plate. Patients present with pain that is progressive at the site of the tumor. As these tumors often occur adjacent to a joint, there can be decreased range of motion, a limp, muscle atrophy, and tenderness over the affected bone. Most chondroblastomas are found in the distal femur, the proximal tibia, the proximal humerus, proximal femur. I've seen chondroblastomas in the calcaneus and flat bones. Less than 1% develop benign pulmonary metastasis from chondroblastomas, just like we spoke about osteoblastomas. Less than 1%. Keep this in mind, please. What's the imaging appearance? Chondroblastomas are small. They are round tumors that occur in the epiphysis or apophysis. What is the differential diagnosis? Yeah, in the older individual, giant cell tumor. In the younger individual, subacute osteomyelitis. And one should not forget the tumor mimicker, eosinophilic granuloma, which can arise in the epiphysis. Most are 1 to 4 centimeters in size and have a sclerotic rim. Most are centrally located in the epiphysis, with a small subset having a more aggressive appearance due to secondary aneurysmal bone cyst formation. I have repeatedly told you that secondary aneurysmal bone cysts do occur in chondroblastoma. do occur in fibrosarcomas, do occur in giant cell tumor, do occur in osteosarcoma. Be careful. If somebody says the pathology is as an aneurysmal bone cyst, tell them I want more investigation. Before you are sure that it's a benign tumor, make sure that it's not arising on a malignant tumor. Cortical expansion of the bone may be present, as occurs in the slide that I'm showing you on the right-hand side. But soft tissue extension is rare. 25 to 40% of chondroblastomas have stippled calcification within the lesion. The differential diagnosis includes giant cell tumor, as I mentioned, osteomyelitis, and don't forget in the adult, around 30 to 40, clear cell chondrosarcoma. You have to be careful about this. Don't forget that in adults, you have to think of giant cell tumor and clear cell chondrosarcoma. Three-dimensional imaging is not required, but a CT scan defines the bony extent of the lesion. MRI shows extensive edema surrounding the lesion. These are cut. You see that the lesion is in the epiphysis of the proximal tibia and of the distal femur. These are various other lesions of chondroblastomas. They can be large, expand the bone. They are known to metastasize in less than 1% of the cases. The treatment is a problem because the physis is still open. And if you want to correct and bone graft, you can damage the physis. So the surgeon, when he goes in, is not very aggressive. Therefore, the recurrence is high. So you have to pay attention to this. The tumor consists of a background of mononuclear cells, scattered multinucleated giant cells, and focal areas of chondroid. The mononuclear stroma cells are distinct round. They are S100 plus cells with large central nuclei that can appear similar to histiocytes. The nuclei have a longitudinal groove resembling a coffee bean. These are various lesions. You can see that there are giant cells. These are giant cells. And this is what I was speaking about, the chicken wire appearance. مثل قفص الدجاج. But you can see it's well bounded. It has a radiolucency. There is calcification within the lesion. Chicken wire calcifications are present in a lace-like pattern throughout the tumor. Mitotic figures are present, but not atypical. 1/3 of chondroblastomas have areas of secondary aneurysmal bone cysts. So please be careful. Treatment is curettage and bone grafting is indicated for the treatment. Adjuvants such as phenol or liquid nitrogen are often used to decrease local recurrence. The local recurrence is 10 to 15%. Surgical resection is indicated for rare benign pulmonary metastasis. Now we come to chondromyxoid fibroma. I know you as residents and fellows who are attending. When you're seeing these, you're going to say, عم بلبك لنا حياتنا فيهم. لا. When you know them, you're more secure. When you know them, when you're looking or examining a patient, you would know what you're examining and searching for. So don't forget these. Don't forget these lesions. A chondromyxoid fibroma is a rare, benign cartilage tumor containing chondroid, fibrous tissue, and myxoid tissue. Most chondromyxofibromas occur in the second and third decades of life, but they may be seen in patients up to 75 years of age. There is a slight male predominance. Chondromyxoid fibroma is thought to arise from remnants of the growth plate. Most patients present with pain and mild swelling of the affected area. Occasionally, the lesions are noted, incidentally. The most common locations are the long bones of the lower extremities, proximal tibia, and pelvis. Small bones of the hands and feet are also affected. Chondromyxoid fibroma is a lucent, eccentric lesion found in the metaphysis of long bones. It can cause thinning and expansion of the adjacent cortical bone. It often has a sharp, scalloped, sclerotic rim, as is shown in this slide. You see, many times you say, doesn't this look like a periosteal chondroma? No, it doesn't, because you see it's eroding into the medullary cavity. And within the medullary cavity, you see sclerosis. The histologic appearance of chondromyxoid fibroma shows hypercellular region at the periphery of the lobules. There is spindle, stellate cells, and myxoid stroma. Look, you see, this is the myxoid, the matrix, which is hyalinic in nature. It's cartilaginous. You see, the activity is at the periphery of the lesion, right over here. Okay? And you see various types of cells. Radiographic calcifications within the lesion are rare, not compared to in chondromas. Chondromyxoid fibroma ranges in size from 2 to 10 centimeters. The radiographic differential diagnosis includes aneurysmal bone cyst, chondroblastoma, and non-ossifying fibroma. There is increased tracer uptake within the lesion on bone scan. On low power, the lesion is lobulated with peripheral hypercellularity within the lobules. The cells are spindled or stellate with hyperchromatic nuclei. Between the lobules are multinucleated giant cells and fibrovascular tissue. This shows you of how it's lobulated, tells you about the character of the cells. It's not very aggressive. Okay, so it's a cartilaginous lesion. Look at the stellate, the spindle-shaped cells. the hyaline type of matrix. Areas of myxoid stroma are present, but hyaline cartilage is rare. The cellular areas may resemble chondroblastoma. Areas of pleomorphic cells with bizarre nuclei are common. The histologic differential diagnosis is chondroblastoma in chondroma and chondrosarcoma. Chondromyxoid fibroma is treated with curettage and bone grafting, and the local recurrence rate is 10 to 20%. Now we come to a more interesting part of the lectures, non-ossifying fibroma, which is very common. We see it in many children, where you have a defect or a disturbance in bone formation. It can occur in the metaphysis and the diaphyseal metaphyseal region. It is a developmental abnormality related to faulty ossification rather than a true neoplasm. It's very common, and it occurs in children from 5 to 15 years. 30% of children with open physis have non-ossifying fibromas, also frequently called fibrous cortical defect or metaphyseal fibrous defects. The etiology, actually, we think it's a disturbance in growth, but we really, again, are not very sure. It's usually due to a disturbance in subperiosteal osteoclastic resorption during remodeling of the metaphysis. Usually, it is an incidental finding, and this is very true. It may be multifocal, familial multifocal. Neurofibromatosis should be included. Jaffe-Capanacci syndrome, which is congenital with café au lait pigmentation, mental retardation, and non-skeletal abnormalities involving the heart, eyes, and gonads. It's most common in long bones of the lower extremity, 80%. Patients are occasionally present or present as a insufficiency fracture. This shows you multiple lesions. You can see numerous giant cells. You can see pleomorphic cells, no mitosis, but you can also, if you search more and more, you can find hemosiderin-laden cells. Hemosiderin-laden. So it consists of spindle cells, giant cells, and hemosiderin-laden cells. It's eccentric, lytic, cortically based lesions with a sclerotic rim. It occurs in the metaphysis and appears to migrate to the diaphysis as bone grows. It may thin the overlying cortex with expansion of the bone. Lesions enlarge from 1 to 7 centimeters as patient grows. As the patient reaches skeletal maturity, the lesions ossify and become sclerotic. This is a larger view. You see it's spindle-shaped. A variety of different sizes, hyperchromatic. They are giant cells. You don't see much mitosis, and you should search for hemosiderin-laden cells. These are all views with this lesion. And I'm showing this to show you the hemosiderin-laden cells. It appears brownish, light brownish on the microscope. This is one over here, over here. I'm trying to see over here you have some. This is the lesion complicated by a insufficiency fracture. If the lesion involves more than 50% of the diameter and is more than 2.5 centimeters in diameter of the bone, you should do something because you'll have an insufficiency fracture. Occasionally, I wanted to return. It's not returning. The pathology, you have a prominent storiform pattern of fibrohistiocytic cells. Variable numbers of giant cells exist. They may have areas of xanthomatous reaction with foamy histiocytes. They have prominent hemosiderin and occasional secondary aneurysmal bone cysts do occur. Treatment, most are treated with observation because they will spontaneously regress. One should monitor along with skeletal growth if they are large lesions, and when symptomatic and large curettage and bone grafting is often necessary. For pathologic fractures, these often allowed to heal, then observe or perform curettage with grafting. Internal fixation is rarely needed, depending on the anatomic location, the diameter of the lesion, how big it is. Fibrous dysplasia, the shepherd's crook deformity. This is a patient of mine, fibrous dysplasia. She had severe scoliosis. She had these lesions, multiple lesions. Okay? And it's a disaster because this is a condition where you have fibrous tissue. It gives you the Chinese appearance, but the fibroblasts don't change into osteoblasts, or if they have osteoblasts, they are ineffective and they don't form bone. Fibrous dysplasia is a common developmental abnormality characterized by hamartomatous proliferation of fibroosseous tissue within the bone. They can be found in any age, but approximately 75% in patients less than 30 years. It affects females more than males. The etiology, it's a solitary, focal, or generalized multifocal inability to produce mature lamellar bone. I mentioned that the osteoblasts are not normal. If you put bone graft in the area, it will be resolved. especially if you put cancellous bone. If you put cortical bone, it will last longer. Areas of the skeleton remain indefinitely as immature, poorly mineralized trabeculae, and it is not inherited. You see, this is the trabeculae and the tissue that surrounds it, which is spindle-shaped. You see giant cells, and you can see occasionally hemosiderin-laden cells. You see this tissue surrounds the trabeculae. The osteoblasts that bound these trabeculae are not normal. They don't form bone. It can be monostotic, meaning localized, or polyostotic, multiple areas, associated with activating mutations of GS alpha on chromosome 20q13, which produce a sustained activation of adenylate cyclase camp. Fibrous dysplasia has high expression of fibroblast growth factor 23, which may be the cause of hypophosphatemia in patients with McCune-Albright syndrome or oncogenic osteomalacia. Usually, they are asymptomatic and found incidentally. They can be monostotic or polyostotic. It affects any bone, but predilection for proximal femur, rib, maxilla, and tibia. Fatigue fractures through the lesion can cause pain and may have swelling around the lesion. Severe cranial deformities, blindness with craniofacial involvement. Patients occasionally present with pathologic fractures. The McCune-Albright syndrome. If you look at this patient, you see it involves one side more than the other. And you see that they have café au lait spots. And you can see that one shoulder is elevated as compared to the other, indicating that this patient has scoliosis. It's a triad of polyostotic fibrous dysplasia, precocious puberty, and pigmented skin lesions, the coast of Maine. Okay? It has unilateral bone lesions, as I pointed out. The skin lesions usually on the same side as the bone lesions. And if it's unilateral, the skin lesions are more likely to be unilateral on that same side. 3% of patients with polyostotic fibrous dysplasia have it, being polyostotic. You have also a myriad of endocrine abnormalities with polyostotic forms. The most common entity using oncogenetic or genic osteomalacia, renal phosphate wasting due to FGF23. And don't forget about the Mazza-Brown syndrome, which is afibrous dysplasia, usually polyostotic, associated with soft tissue, intramuscular myxomas. Intramuscular myxomas. Radiographically, they have central lytic lesions within the medullary canal, usually diaphysis and metaphysis. They have a sclerotic rim, maybe expansile with cortical thinning. They have a ground glass appearance or a shower door glass. مثل يلي عم تاخد shower ما في الازاز which is not transparent. We call it shower door glass appearance. You have bowing deformities in the proximal femur, shepherd's crook, or tibia. It can see vertebral collapse and kyphoscoliosis, long lesion and long bone. You have increased activity on bone scans, but plain radiographs usually are diagnostic. This shows you the various lesions, and it shows you of how it appears like Chinese letters, spindle shape. They have a yellow-white gritty tissue. Histology is poorly mineralized, but immature fibrous tissue surrounding islands of irregular, often poorly mineralized trabeculae of woven bone. They have Chinese letters and alphabet soup appearance. Metaplastic bone arises from fibrous tissue without osteoplastic rimming. Common is mitosis. It may have metaplastic cartilage present or areas of cystic degeneration. It can be associated with a secondary aneurysmal bone cyst, as I have repeatedly mentioned about fibrous dysplasia or fibrosarcomas. All have been associated. The differential diagnosis includes a low-grade intramedullary osteosarcoma. The treatment is asymptomatic patients may be observed. Surgical indications include painful lesions depending or impending actual pathologic fracture, severe deformity, and neurologic compromise. Fine. Let me tell you, I received recently a patient who has multiple lesions in the spine, in the ribs, etc., and has a severe scoliosis, severe, with a high angle measuring around 70 degrees in the thoracic region. And she's suffering. What to do? How can you fix this? How can you hold this? These are these patients. When they arrive to you, they put you in a crossword puzzle. Okay? And you have to think of neurologic compromise and all the problems. Curettage and bone grafting of the lesion. You should use cortical allograft, not cancellous autografts, because they will be resolved. Cancellous autografts are replaced by dysplastic bone. Usually, it requires internal fixation to achieve pain control. You have an intramedullary device, which is often inserted, which is preferable to insertion of a plate because it shares the load, the lower extremity. Osteotomies for deformity. Medical treatment with biphosphonates provided good pain relief in small areas. In approximately 1% of lesions, malignant transformation to osteosarcoma, fibrosarcoma, or malignant fibrohistiocytoma occurs with extremely poor prognosis. Osteofibrous dysplasia. Are there any questions? Am I clear?
very clear. دكتور جون.
عم تسمعي يا خالد؟
ايوه عم نسمعك. كل شيء واضح.
Are you finding it boring or interesting?
Very interesting.
طيب هلا رح نحكي عن osteofibrous dysplasia. This is very interesting. Why? Because this is a lesion that is equivalent in a child to an adamantinoma. Osteofibrous dysplasia is a non-neoplastic fibro-osseous lesion affecting the long bones of young children. It affects males more than females. And usually it's noted in the first decade of life. The etiology is trisomy of 7, 8, 12, and 22 have been reported. Unique predilection for the tibia. Adamantinoma has a unique predilection for the tibia in an adult. They can have anterior or anterolateral bowing deformity. In osteofibrous dysplasia, if they have fractures, they could end up with pseudoarthrosis in 10 to 30% of patients. Patients usually present with painless swelling over the anterior border of the tibia. Eccentric, well-defined anterior tibial lytic lesions are seen. You should know that it is usually diaphyseal. Single or multiple lucent areas surrounded by dense sclerosis. It is confined to the anterior cortex and may expand. There is no periosteal reaction, as occurs with the Ewing sarcoma. The differential diagnosis is adamantinoma. The radiographic appearance is identical. So if we put a question, you have a lesion known to be an osteofibrous dysplasia in an adult. Which of the following is the equivalent lesion? And we give you 5, one of which is adamantinoma. You should choose adamantinoma. This is a typical case of osteofibrous dysplasia of the tibia. You see it over here. It's what consists of woven bone arising from fibrous stroma. The new bone is prominently rimmed by osteoblasts, thus distinguishing this from fibrous dysplasia. طلعوا هون طلعوا على trabeculae تشعوا في كتير osteoblasts, while بالfibrous dysplasia أنجا تقشع osteoblasts. Don't forget, in fibrous dysplasia, if you put cancellous bone autograft, it will be resolved and changed into fibrous tissue. If you want to use a bone graft in fibrous dysplasia, it's got to be cortical bone, especially if it's in allograft. So you have to be careful. Over here, the bone and the osteoblasts are normal. Fibrous dysplasia, it's not. Moderately cellular fibroblastic stroma is seen. Islands of woven bone with prominent osteoblastic rimming. There is no cellular atypia and may have giant cells, and the differential diagnosis is fibrous dysplasia. Now we come to the dangerous lesion. If it copies all bones, and it can be confusing. And this is eosinophilic granuloma. If you look over here, you can see lesions in the pelvis, in the greater trochanter also, and this is typically an eosinophilic granuloma. If you look at the right-hand slide, you see a silver dollar sign, which is typical of an eosinophilic granuloma in a child. And these lesions can reform their shape or regrow to a normal vertebra, while another lesion occurs in a different place. And this is called the tempo phenomenon. The flattened vertebra is called the silver dollar sign, while lesions occurring in different places in the vertebral bodies are called a tempo phenomena. Langerhans cell histiocytosis is a clonal proliferation of Langerhans type histiocytes, which consists of large amount of Berwick's granules that can have multiple clinical presentations. These are most common in children. 80% are less than 20 years of age, and the male to female is 2 to around 1.5. You see over here the lesions. It can occur in the distal end of bones. It's lytic. It seems to be geographic in nature, and it is well bounded. Previously categorized as eosinophilic granuloma, Henschel Christian disease, and glittery seaweed disease. Now believed to be 3 scenarios separate. Solitary disease is eosinophilic granuloma. Multiple bone sites are Henschel Christian disease, and Henschel, you can have involvement of eyes with exophthalmos, mastoid process, punched out osteolytic lesions, and so on and so on. Multiple bony lesions, of course, we said about Henschel. Multiple bony sites with visceral involvement, lungs, liver, spleen, skin, and lymph nodes are known as glittery seaweed disease. Really, bone lesions are asymptomatic. Really, bone lesions are asymptomatic. Usually, they cause localized pain, swelling, limp. It can occur in any bone, but most commonly the skull, the ribs, clavicle, scapular vertebrae, thoracic, lumbar, cervical, and long bones. I would like to mention that they present as punched out osteolytic lesions, and they have a bevering appearance in the skull. Ya Allah. Okay. So the classic appearance is a punched out osteolytic lesion. They may have thick periosteal reaction. They can appear well demarcated or permeative. Commonly, it causes vertebral collapse, vertebra plana, when affecting the spine. Great mimicker of other lesions known as osteomyelitis, Ewing sarcoma, and leukemia. This enters the differential diagnosis of eosinophilic granuloma. The pathology. The characteristic tumor cell is Langerhans cell or histiocyte. Histiocytes have indented nuclei, coffee bean appearance, with an eosinophilic cytoplasm. The histiocytes stain with CD1A. Giant cells are present. Eosinophils are variable in number. Mixed inflammatory cells infiltrate. Berbic granules are present on electron microscopy tennis rackets. Solitary lesions can be treated effectively with an intralesional injection of methylprednisolone acetate. Curettage bone grafting, if open biopsy is being performed for the diagnosis. In 90% of patients with vertebra plana due to Langerhans cell histiocytosis, bracing alone will correct the deformity without treatment. 10% will need corrective surgery. Low-dose radiation is used in rare cases in lesions which are difficult to arrive at. We give radiation. Patients with disseminated disease and visceral involvement can die of the disease. The prognosis is improving with more effective chemotherapy like Velvet, but worsens with increasing number of extraosseous sites of disease. Unicameral bones, I'm sure everybody knows about. Unicameral bone cysts say that it could be either a venous obstruction or a hematoma. And when it first arrives, it is present close to the physis, and with growth, the lesion displaces distally. We can say whether the tumor or this benign lesion is healed and growth is nearly stopping once it becomes at some distance from the physis. It's common. If you put a needle in it, you have serous fluid. You have a filled bone lesion, which has serous fluid. Most cases occur in patients younger than 20 years. It's thought to result from a temporary failure of medullary bone formation near the epiphyseal plate during skeletal growth. The cyst is active initially when adjacent to the growth plate. When medullary bone formation resumes, the cyst appears to move into the diaphysis. Possible causes and precursor lesions include lymphatic venous obstruction, intraosseous hematoma, or intraosseous synovial cyst. If you take a unicameral bone cyst from one side and an aneurysmal bone cyst, let us see what is the difference, because I'm asked this many times. In a unicameral bone cyst, you can present with a pathologic fracture. Why do they present with the pathologic? Because they don't know that they have the lesion. And it occurs when they're playing basketball or volleyball. They have the fracture, they're brought to the emergency room, and you see that they have a unicameral bone cyst. They never complained of anything. In an aneurysmal bone cyst, they have pain from the very start and swelling. The common locations are the proximal humerus of the unicameral bone cyst and proximal femur. I have reviewed several of these cases, and they start first being proximal, very close to the physis. In aneurysmal bone cyst, the common location is the distal femur, proximal tibia, pelvis, and posterior elements of the spine. Radiographic characteristics include a central lytic lesion, mainly in the metaphyseal region, has a symmetric expansion, less than the width of the growth plate. Yeah, you see that it is expanded from both sides. While in aneurysmal bone cyst, you see eccentric lytic lesion metaphyseal and can expand wider than the growth plate, and it extends into the soft tissues with a thin periosteal rim. Treatment is in unicameral intralesional steroid injection, curettage, grafting, internal fixation, and proximal femur, proximal humerus and femur. Curettage and bone grafting is the treatment for aneurysmal bone cyst with embolization, especially lesions of the spine and pelvis. These show you various lesions, unicameral bone cyst, shows you the pathology, clinical presentation. The most common presentation is a pathologic fracture after minor trauma. Painful symptoms resolve when the fracture heals. Most common locations include the proximal humerus, proximal femur, but unicameral bone cysts can occur also in the ilium and calcaneus. Purely lytic lesion located centrally in the medullary canal. Unicameral bone cysts start metaphyseal, adjacent to the growth plate, and appear to progress towards the diaphysis with bone growth. Narrow zone of transition exists between the cyst and normal bone. Cortical thinning, but no soft tissue extension. Bone expansion does not exceed width of the physis. They often have multiple fractures, and being that there are no loculations, if you have a small fracture, a leaflet fracture, you'll see that it will fall within the cyst and settle down at the bottom of the cyst. This does not occur in aneurysmal bone cyst. Why? Because it consists of loculation. Plain radiographs are usually diagnostic, but MRI shows a well-defined zone of bright uniform signal on T2 weighted imaging. Pathology, lining of the cyst is a thin fibrous membrane. There's no true endothelial cells. Giant cells, inflammatory cells, hemosiderin within the lining, clear or serous fluid within the cavity, bloody after fracture. 10% contain cementum spurious, calcified eosinophilic fibrinous material in the lining. The natural history to fill in with bone as the patient reaches skeletal maturity. After acute fractures, the lesion will occasionally fill in with native bone in 15% of cases. Standard treatment is intralesional injection of methylprednisolone acetate. Many require multiple injections, especially in very young children. Proximal femoral lesions, with or without a pathologic fracture, often treated with curettage, bone grafting, and internal fixation. Aneurysmal bone cells. If you look at these x-rays, you see one of the things which is not present in unicameral bone cells is the expansion of the lesion, ballooning out of the lesion into the soft tissues. It is well demarcated by a shell. It can completely destroy a small bone, as has occurred in the fourth metacarpal bone. It can expand. It expands out. This does not exist with a unicameral bone cyst. So you have a destructive, expansive, reactive bone lesion filled with multiple blood-filled cavities. I repeat, multiple blood-filled cavities, which indicate why they don't get the leaflet sign or the falling leaf sign. Why? Because they have loculations. It cannot pass to the base of the lesion. 75% are younger than 20 years of age. The etiology, it is reactive, non-neoplastic process of unknown etiology. The possibilities include a traumatic origin of a circulatory disturbance leading to increased venous pressure and hemorrhage. It can arise de novo or be associated with an underlying lesion that is identifiable in 30% of cases, and most commonly chondroblastoma, as I repeatedly mentioned, giant cell tumor, chondromyxoid fibroma, non-ossifying fibroma, osteoblastoma, and fibrous dysplasia. Pain and swelling are the most common symptoms. Pathologic fracture as a presenting symptom is rare. Neurologic symptoms are possible with lesions in the spine. Most common locations are the distal femur, proximal tibia, pelvis, spine, and posterior elements. This shows you a lesion occurring in the vertebral body. It can spread or extend from one vertebra to a neighboring vertebra. In the X-ray of the tibia, you can see the expansion of bone. This does not occur in unicameral bone cysts, and likewise in the distal femur. Eccentric lytic lesions located in the metaphysis is shown in the slide. It can aggressively destroy, expand the cortex, and extend into the soft tissues. Lesions can expand to greater than the width of the epiphyseal plate, usually maintains a periosteal rim around the lesion. This is what we call the shell. It can grow contiguously across adjacent spinal segments or extend through the epiphyseal plate. No matrix mineralization exists. MRI shows fluid levels on T2 weighted images, separation of serum and blood products. Radiographic differential diagnosis includes unicameral bone cyst and telangiectatic osteosarcoma. This shows you the expansion, can occur in the center, can occur at the periphery. It can grow contiguously across adjacent spinal segments or extend through the epiphyseal plate. No matrix mineralization is seen. MRI shows fluid levels on T2 weighted images, separation of serum and blood products. Radiographic differential diagnosis includes unicameral bone cyst, telangiectatic osteosarcoma. These are the fluid levels. Blood-filled cyst without a true endothelial lining. Lining contains giant cells, new woven bone spindle cells. Solid areas are common. It may be histologic evidence of underlying primary lesion. No cellular atypia, but mitosis are common. Histologic differential diagnosis includes telangiectatic osteosarcoma and giant cell tumor. This is a multinucleated giant cell with fibrohistiocytic stroma. There's no cellular atypia is seen, no endothelial lining. Surgical treatment is curettage and bone grafting of the lesion. Local adjuvants, phenol, can be used after curettage. Highest local recurrence is in patients with open physeal plate. For local recurrence, repeat curettage and grafting is indicated. It may resect expandable bones, namely the proximal fibula. Embolization can be used for pelvic or spinal lesions, alone or in combination with surgical treatment. We have used Portio as a treatment in patients with aneurysmal bone cyst, and had, in a few cases, very good result. Embolization is done for lesions within the pelvis or spinal lesions. Giant cell tumor. I would like to take Khalid 5 minutes break. 5 minutes break.
اوكي دكتور جون take your
لحتى ريح صوتي يا خالد.
ما حاضر تشرب لك شيء دافي الله يحفظك. شكرا.
لا عم بشرب مي عم بشرب مي.
يلا
tumors are known to giant cell tumors are known to occur in areas of rapid growth, such as around the knee, distal femur, proximal tibia, known to occur in the distal radius, does occur in the spine, and let's go through them. It is an aggressive lesion. If you look at the X-ray of the distal radius, you can see what is the tumor doing to bone and what is the host doing to the tumor. You can see that there is not a clear-cut sclerosis of the lesion. It is rather not clearly defined as the boundary of the lesion. If you look at the pathology on the right side, you see that giant cells are numerous. You have monoblastic cells, or these cells in the matrix usually unite together to form the giant cells. Now, in the past, there has been much agreement or much disagreement, whatever you want to call it, as far as to judge whether a giant cell tumor is benign or malignant. In the past, we used to look at the giant cell and look at the boundaries of the giant cell. The boundaries. If it's smooth, we'd say that this is more or less benign. Or if it's irregular, then we would say that it's more aggressive. If you look at the cells in the matrix, they can unite and form the giant cell. Giant cell tumors is a benign, aggressive bone tumor consisting of distinct, undifferentiated mononuclear cells. It most occurs between 30 and 50 and more common in females than males. The etiology is unknown. Stromal cells have alterations in the C-mic, C-phos, N-mic, and oncogenes. Pain and swelling for 2 to 3 months are the main symptoms. Decreased range of motion around the joint, for instance, a lesion within the knee, they will have limitation of motion due to pain. Sometimes it presents with a pathologic fracture in 10%. It's located, as I mentioned, around the distal femur, proximal tibia, distal radius, proximal humerus, proximal femur, sacrum, and pelvis. 1% of cases are multicentric. This shows you multiple areas of involvement of a giant cell tumor. One is packed with cement, and you can see it in the pelvis, you can see it in the inferior pubis, you can see it in the proximal humerus, distal radius. All these are popular sites for this lesion to occur. Eccentric lytic lesions located in the epiphysis, metaphysis of low bones. They may arise in an apophysis, lesions extend to the subchondral surface with no sclerotic rim. They can destroy the cortex and extend into the surrounding tissues. These are the various lesions: distal radius, distal femur, resection, numerous giant cells. Look over here, the giant cells, the boundaries are irregular. Look at this. The boundary is irregular, and this giant cell tumor was aggressive. It's located in the anterior vertebral body when involving the spine. It can also involve the sacrum, but the difference between it and the chordoma is the chordoma is usually central, while a giant cell tumor is usually unilateral or slightly lateral, not central. It may be associated with soft tissue calcifications. They commonly have a secondary aneurysmal bone cyst. Bone scan shows increased uptake in the lesion. MRI is helpful only to define the extent of soft tissue involvement, as plain radiographs are usually diagnostic. The pathology, gross, they have soft red, brown, hemorrhage, necrosis. The histology is uniformly scattered. They have multinucleated giant cells within a background of mononuclear stroma cells. It shows it repeatedly. The stromal cells resemble the neoplastic cell. They have secondary changes of necrosis or fibrohistiocytic change. Mitosis are frequent, but there should be no cellular atypia, no matrix production unless there is a pathologic fracture. They have an association of aneurysmal bone cyst. There is no histologic grading system for giant cell tumor or way to predict the prognosis. Most lesions can be treated with thorough curettage and high-speed burn. Why do we use the high-speed burn? Ya Jamea, if you're treating a giant cell tumor, you should make a wide opening in the cyst so as not to miss any areas. And what you should do, you should burn, irrigate, put phenol, then irrigate, then burn. Why? Because they have pseudopods. The tumor infiltrates or penetrates bone through pseudopods. One reaming is not enough. Another point, when you're treating the articular side of the lesion, you should put cancellous bone if you're going to use cement. Cancellous bone on the articular surface from inside, because this will prevent erosion of the cartilage with time. We use a lot of phenol in the treatment, and believe me, we see quite a number of these cases in our centers. So you need thorough intralesional treatment, requires making a large cortical window. Local adjuvants are commonly used to decrease local recurrence. Phenol, cryotherapy, argon, beam, all have been used. You can fill the defect with either bone graft or methylcrylate recurrence rate, or with or without internal fixation. We don't believe, in spite of it being reported in the literature, in putting cement without bone graft. We put the bone graft at the articular margin. Then we put the cement. If you want to use bone, fine, you can use it without doing such. But with cement, you have to put the bone between the cement and the articular surface. the patient with cement, the advantage is that they can bear weight as tolerated after using methylcrylate. It protects from weight bearing after using bone grafting until consolidation. Local recurrence with intralesional treatment is 10% to 15% recurrence. Local recurrence can be in the adjacent bone or manifest as soft tissue masses. Aggressive lesions may require resection and reconstruction. Embolization should be used for large pelvic or spinal lesions alone or in combination with surgical treatment. Radiation occasionally is used in multiply recurrent or surgically inaccessible lesions. Metastasis to the lungs occurs in 2% of the patients. Benign metastasizing giant cell tumors. Treatment includes thoracotomy, radiation, chemotherapy, or observation. 10% to 15% of patients with metastatic disease die of the disease. Rare cases, approximately 1% of malignant giant cell tumor. We try not to use radiation as mentioned. Chemotherapy we rarely use because we have no evidence till the present that it is effective. The take-home message in benign lesions before we finish the first lecture. Osteoblastoma has a radiolucent needles with surrounding sclerosis. The bone scan is always intensely positive in an osteoblastoma. Thin-cut CT scans most often identify the needles and make the diagnosis of osteoblastoma. The proximal femur is the most common location for an osteoblastoma. Osteoblastoma is the most common cause of pain for scoliosis in a young patient. And it is important, usually the scoliosis appears at the wrong time and place. And usually the lesion is present on the concave side of the lesion. And if you resect an osteoblastoma or use radiofrequency or a burn down technique, and this disappears. And this is done before the tumor was present for 1 year. The curve will revert to normal. They will change to normal shape. Radiofrequency is the current standard of care to treat an osteoblastoma. Osteoblastoma, by its smaller, I have to change this. Let me see. An osteoblastoma can be differentiated from an osteoblastoma by its smaller size and less aggressive behavior, although histologic appearance is similar. Osteoblastoma is a large radiolucent lesion that occurs most commonly in the posterior elements of the spine. Parosteal osteoma must be differentiated from parosteal osteosarcoma. A bone island is an inactive lesion most commonly found in the pelvis and proximal femur. Enchondromas are usually asymptomatic. A painful presentation is usually due to unrelated condition. Enchondromas don't cause pain. You discovered them by chance. But when you see that there's a patient with an enchondroma but has a lot of pain, you should search for everything else before arriving to enchondroma being the cause. The clinical presentation and radiographic appearance are more important than the histologic appearance in differentiating an enchondroma from low-grade chondrosarcoma. Patients with either Ollier disease or Maffucci syndrome have an increased risk for malignant transformation of an enchondroma to a low-grade chondrosarcoma. A periosteal chondroma is a surface lesion that creates a saucerized defect in the underlying cortex. The medullary cavity of the underlying bone is continuous with the stalk of an osteochondroma. Secondary chondrosarcomas arising from osteochondromas are low-grade and occur more often in patients with multiple lesions. EXT1, T2, and T3 are genetic loci commonly mutated in patients with multiple hereditary exostosis. Chondroblastoma most commonly occurs in the physis, epiphysis, and apophysis of long bones. Chondroblastoma rarely metastasizes, less than 1% to the lung. Chondromyxoid fibroma is a lucent eccentric lesion with sclerotic scalloped rim seen in long bones, pelvis, and hands and feet. Non-ossifying fibromas are usually incidentally findings that spontaneously regress and should be observed. Non-ossifying fibromas are developmental abnormalities that occur in 30% of children. Non-ossifying fibromas occur as scalloped lytic lesions with a sclerotic border within the metaphysis. Fibrous dysplasia is a long lesion in a long bone with a ground glass appearance. The histologic appearance of fibrous dysplasia is woven bone shaped like Chinese letters or alphabet soup in a cellular fibrous stroma. Polyostotic fibrous dysplasia occurs in McCune-Albright syndrome along with precocious puberty and café au lait spots. Osteofibrous dysplasia affects children in the first decade with a predilection for anterior cortex of the tibia. The histologic appearance of osteofibrous dysplasia is a cellular fibrostroma with prominent osteoblastic rimming around the woven bone, which differentiates it from fibrous dysplasia. Langerhans cell histiocytosis is the great mimicker think of it with lytic lesions in children. In Langerhans cell histiocytosis, the histocyte, not the eosinophil, is the tumor cell and stains with CD1A. Unicameral bone cysts are centrally located in the metaphysis and appear to move to the diaphysis. Unicameral bone cysts present with a pathologic fracture, a rare fallen leaf sign on radiographs. Treat unicameral bone cysts with intralesional steroid injections. Aneurysmal bone cysts are destructive, expansile, blood-filled cysts. Aneurysmal bone cysts occur around the knee, pelvis, and posterior elements of the spine. مشكلة ما بتغير. At least 30% of the time, aneurysmal bone cysts are secondary to an underlying primary bone tumor. I have stressed this. Giant cell tumors are epiphyseal or apophyseal, extend into the metaphysis and subchondral bone. The mononuclear stroma cell in neoplastic cell in giant cell tumor. So it is the neoplastics, the mononuclear. The treatment of giant cell tumors is carefully curettage with large cortical window, low local recurrence rates of 5 to 15%. And giant cell tumors to the lung, they metastasize in 2% of the patients. Now, we finished the first part of the lectures. Can I know whether there are any questions now to mention? How many of you have any questions?
دكتور جون.
ايه
دكتور محمد،
شو
في سؤال بس على الجاينت سيل تيومر، انه يعني التندنسي للمالجنسي is very high.
ما فهمت شو
التندنسي للجاينت سيل للمالجنسي تشنج المالجنسي يعني you say about
2%. مش أكثر. But the problem, giant cell tumor is an aggressive tumor. It is aggressive. You know, we have 3 types of giant cell tumors. We have a giant cell tumor which is quieter. We have a giant cell tumor which is aggressive.
active.
نعم.
But يعني دي يعني management of giant cell tumor, what is the augmentation we use يعني
What
يعني
نعمل لك what I will do. Do you mind?
What is the best of them?
What is what?
The best choice to avoid
treatment,
the recurrence.
The best treatment. Okay, I'm going to tell you what I do. You see, I use Prolia a lot. I use Fortio a lot. Fortio, I use it, and I use Prolia. Prolia, we use it more often to encourage bone formation. Recently, we have been using Fortio in an experimental manner.
Mhm.
Now, going to prolia, we give it for some time, and we find that the lesion involutes. Now, let me tell you, before that, I used to routinely go into surgery. I used to make a very big window around the lesion.
Yeah.
I used to go in with a rapid speed burr. I used to burr down all the pseudopods repeatedly. لأن مرة واحدة ما بتأدي. You have to do it many times. And routinely, if we're going to use cement, we put bone graft distally between it and the joint. ليش؟ لأن لقينا إذا حطينا cement بلا ما نحط bone graft, biomechanically, this increases the forces on the joint, and you will get degeneration of the joint. Okay, so this is something we don't like. I have received 2 patients which were as such, giant cell tumor. I received a patient that was operated and recurred 4 times. This patient recurred 4 times, and when you go into the literature, if you operate a patient with a giant cell tumor and it recurs several times, you increase the chances of metastasis. Okay? So, the 5th time, I didn't want to operate. I haven't operated any of the cases before. The 5th time, I wanted to make sure that this tumor will not recur. And what I did, I resected half of the joint and used a total knee arthroplasty. And this patient was done 21 years ago. And recently, I saw the patient. She teaches ballet, and she's very happy. Second case was a giant cell tumor who had his lesion in the distal femur. He was operated before, and it recurred. He was older than my patient, the first patient. There was a difference in 20 years. And was operated once before. I mentioned to the patient that I would like to replace the joint, because if it does recur, and it recurs, the more it recurs, the more the chances for spread of the tumor. So the patient didn't listen to me and went and was operated elsewhere, and the patient ended up with metastasis and succumbed to his disease. A third patient I have received from Syria. The patient was brought to me in one of our conferences, and in this conference, we were me and Debussy, plus other French specialists. And I advised using Prolia. On giving Prolia for 6 months, the patient was brought back to me, and believe me, the lesion disappeared. So you have to know that Prolia has an effect on these patients. And recently we have been trying Fortune, okay, 134 or 35 paratorma. And I'll tell you, we're waiting to see the result. I hope I answered the question. Giant cell tumor ملعون.
Yes.
You're right by saying that it's malignant.
I am agree
Huh?
with you. I am agree with you, Dr. June, because the behavior of the tumor is aggressive, is very destructive. Also, the locations of the tumor near the joints, either distal femur or distal radius.
Uh-huh.
So the management of joint cell need experience and care, more care. Thank you very much.
You have to, there is something else I want to tell you. You have to know with, you mentioned location. You have to know that giant cell tumors of distal radius are more aggressive than giant tumors of the knee. You have to pay attention to these.
Yeah.
You have to know these. Okay? Thanks. بعدين رح بلش أنا هلا
يلا.
the second part of the lecture. Let me see if I have water. I want to tell the girl to bring me water with chance to be able to continue to speak. 1 second. London. Come and put it on. Okay. Now, we come to the malignant tumors. And if you notice, giant cell tumor was mentioned as the last tumor, where we consider it to be more or less malignant. Malignant bone tumors in children are very rare. In fact, most physicians will see a few patients with symptoms of an undiagnosed primary bone tumor throughout their careers. غريب إنه ما عم بتغير. Nevertheless, the pediatric orthopedic surgeon should be able to guide the clinical workup of a pediatric bone tumor and know the relevant differential diagnosis. The two leading primary malignant bone tumors in children are the osteosarcoma and lesions from Ewing's sarcoma family. Osteosarcoma is the most common primary bone sarcoma in children. The incidence is 1 to 3 per million, with a slight male predominance in the United States. Histologically, it is defined as a spindle cell neoplasm that produces osteoid. A question that I am asked in all pathology meetings, in all tumor pathology meetings, in all combinations, how do we demonstrate that the osteoid is tumorous and not benign? It's not the osteoid that lets us judge whether it is malignant or benign. What lets us judge is the osteoblast. Look at the osteoblast. Is it hyperchromatic? Are there various sizes? Judge whether the osteoblast is the aggressive part, and then decide whether your tumor is an osteosarcoma or some other form of tumor.
بس هو ها؟ في ارتري في حاجه لقطه والله كنت وجه لهم حسيتهم سلبيين مع عارف شو يخدموا والله مش تحقيق
شو القصة؟
تشوفهم انت قصدي تدرب وما همش.
What's the question? What is the question? Is there any question I can help?
From our whole, no question. Actually, maybe
There's no question.
No.
لا لأن عم نسمع الارجيومنت تبعهم.
Argument maybe in the Zoom, I think, not from the whole. From our...
طيب. Histologically, it is defined as a spindle cell neoplasm that produces osteo. The characteristic localizations are the metaphysis of long bones in the region of the knee, the proximal humerus, and the proximal femur. Why? Because these are areas of rapid growth. Osteosarcoma rarely occurs in children less than 5 years of age. If you get an osteosarcoma in a child less than 5 years, you have to think of the case that is most commonly associated with the Lee-Fromani syndrome. Other syndromes with an associated risk of osteosarcomas include retinoblastoma, we all know. And if you recall at the beginning of my lecture on benign bone tumors, the Rossman-Thompson syndrome, where they have multiple osteomas, have a predisposition to have osteosarcomas. And there is the Rappadellino syndrome. So all these have been associated with osteosarcoma. Osteosarcoma metastasizes mainly to the lung and bone. About 10 to 20% of patients already have pulmonary metastasis at initial presentation. Long-term survival following multimodal chemotherapy and wide resection lies between 60 and 70%. The Ewing sarcoma family of tumors includes Ewing sarcoma of bone, extraskeletal Ewing sarcoma, peripheral primitive neuroectodermal tumors of bone, and soft tissue and ascent tumor. It is the second most common primary bone and soft tissue tumor in children and adolescents, with an incidence of 2.5 to 3 per million. Histology typically presents a distinctive small blue round sarcoma. The most frequent sites are the pelvis and the diaphyseal and metadiaphyseal regions of long bone. Unlike other primary bone tumors, approximately 20% arise in the soft tissue. The Ewing sarcoma is characterized by chromosomal translocation of the EWSR1 gene on chromosome. They have translocations in the 22 chromosome, T1122 and Q24, Q12. Treatment includes chemotherapy, radiation therapy, and wide surgical resection. 5-year overall survival is about 85% for patients with localized Ewing sarcoma and 27% for patients with metastatic disease, respectively. The The major differential diagnosis of pediatric bone lesions include infection, septic arthritis, Brody's abscess, lymphoma, Langerhans histiocytosis, and benign lesions like aneurysmal bone cysts, osteoblastoma, and osteochondroma. In the spine, location may be helpful to distinguish between entities, malignancies, as well as infection. Langerhans cell histiocytosis or eosinophilic granuloma more often occur in the anterior elements, the vertebral body, whereas benign tumors are more often located in the posterior elements. A meticulous diagnostic workup is important for implementation of the correct diagnosis and successful treatment. This is, I'm stressing this, an interdisciplinary process that includes a proper clinical examination, adequate imaging with the radiologist or the specialist, correct biopsy, where to take the biopsy, the location, what type of biopsy, and histopathological analysis. Early diagnosis of a malignant bone tumor may not only increase the chance of survival, but also the possibility of performing a limb-sparing resection. Unfortunately, the initial symptoms are unspecific, but pain is usually a constant finding. Initially, the pain can be intermittent and related to activity and loading. That's very important. Pain that worsens at night has been described as characteristic of malignancy, but this is not a constant finding. With time, the pain becomes constant without relief and gets worse with activity. Sometimes a lump is present, but usually when it is evident, the disease is already advanced. Bone tumors can weaken the bone and can present as a pathologic fracture. Pelvic and spine tumors can present with neurologic deficits. Past history of malignancy and history of some specific predisposed genetic conditions must be investigated. In children, it is mandatory to make a differential diagnosis with an infection, as this is far more common than a sarcoma. The clinical examination must include the inspection and palpation of the area of tenderness, swelling, or pain, but palpate with gentleness. Don't palpate very firmly because this could spread the tumor. In the past, we used to use an Ismark bandage so as to prevent bleeding, but it was wrong. An Ismark bandage, once you pass it around the tumor, you're squeezing out everything to the rest of the body. If a mass is present, its size, consistency, position, and mobility must be assessed. Local lymph nodes should be palpated. Different imaging techniques are useful to evaluate a bone lesion. Radiography remains the mainstay for initial diagnosis and other advanced imaging modalities, such as MRI, CT scans, bone scintigraphy, positron emission tomography. These are useful in evaluating the extent of the lesion and its local and distant staging. Conventional radiographs are still the first, believe me, in bone tumors. In 75% of the cases, I can make a diagnosis from a simple, plain X-ray. And the most valuable imaging technique to study a bone tumor, it is available in every hospital. And it is a relatively inexpensive technique. Orthogonal radiographs of the area should be completed for all lesions. And you should train. Put the X-rays up. Describe the lesion radiologically. Describe whether it is a benign or malignant. Describe whether it is a geographic or moth-eaten lesion. You have to be able to get used to this. Sit with your friends and discuss each lesion alone. Believe me, it will help you. This is a radiograph of a non-ossifying fibroma. We know that it's benign because we're able to decide what the tumor is doing to the bone and what the bone is doing to the tumor. This is a benign lesion. It's well delineated borders and sclerotic edges can be appreciated. There is no cortical breakage and no soft tissue mass. On the contrary, malignant lesions have undefined borders with a speckled pattern. Break the cortical usually have a soft tissue mass and periosteal the reaction can be observed. This is a Ewing's. Look at it. You see that there's a Codman triangle, which I will be discussing later on. You see erosions. You see that you cannot define the borders of this tumor. Panicking suggested questions to be asked when a bone tumor is suspected in a plain radiograph. Where is the lesion? It is important where the lesion is located, but also which part of the bone. For example, osteosarcoma is usually located in the metaphysis of bone bones. There have been in the diaphysis, but it's more common in the metaphysis. And we know that osteosarcoma usually appears in areas of rapid growth around the knee, proximal humerus. What is the lesion doing to the bone? 3 patterns of bone destruction help us to identify aggressiveness of the bone lesion. Type 1 is a geographic bone destruction that I spoke about. When a lesion has borders well defined with sclerotic margins. 3 pattern and without sclerotic margins, but with a narrow zone of transition, in other form, and lesions with ill-defined or less aggressive lesions. Why is it becoming paused? في حدا عم بيلعب فيها. Type 2 are most eaten appearance when a lesion has I'm مش عارف شيء ما بعرف كيف بدي شيلها هي لازقة علي هاي الصفرة هون. طيب Type 2 lesions are most eaten appearance when a lesion has areas of bone destruction with ragged edges indicative of malignant process rapidly expanding into the bone. And type 3 are permeative appearance when the tumor moves through the bone without destroying the trabeculae, with a zone of transition between pathological and normal bone. What is the bone doing to the lesion? يا الله راح ليه هيدي؟ بجنين هي وقفوا لي اياها الليجن. يلا دقيقة رح برجعها. يا الله. Sorry, I think it's from outside. They're playing around. شايفين يا خالد؟
دكتور جون ايوه يعني بنشوف احنا تمام عندنا واضحه الصوره ايوه
منيح. What is the lesion doing to the bone, or what is the bone doing to the lesion? The response of the bone depends on the tumor histology and grade and the rapidity of its growth. Sunburst or hair on end, preosteal reactions, and the Codman's triangle are typical in malignant lesions. What is in the lesion? نطلع بالlesion. Is it calcified? Is it not? Is it a ground glass appearance? Is it not? All these would tell us from a plain X-ray what the lesion could be. The information provided by the radiograph is limited when the lesion is located in complex anatomical locations, such as in iliac bones and the spine. In posterior elements of vertebrae, the overlapping of structures on two-dimensional planes limits the radiographic interpretation. Also, the radiograph has limitations concerning the evaluation of soft tissue and the precise extent of medullary involvement. The information provided by the radiograph is limited when the lesion is located in complex and two-dimensional بس ما بتغير. A 9-year now we're coming to interest case. A 9-year-old girl presented with pain in the right hip and thigh for 2 months The anteroposterior pelvis radiograph shows an osteolytic lesion in the right pubic bone, ramus inferior ossus pubis. Iliac crest biopsy was consecutively performed and Ewing sarcoma was diagnosed. A coronal MRI scans of the pelvis show a tumor mass extending from the os pubis and infiltrating the obturator externus muscle, and full body positron emission tomography MRI scans were performed to complete the staging. A full body MRI scan. These are the X-rays. إذا بتطلعوا بالإكس-ray in A, you see that there is erosion, a lesion on the inferior pubic ramus, also close to the ischium. Then you see in MRI that you have a huge tumor over here extending to the neck of the femur. You can see it also. This is a total body PET scan showing the lesion, and there was no metastasis. CT scan is a precise anatomical delineation, evaluation of lesions in complex anatomical location. Also, CT allows better visualization of bony changes. It can be very useful, especially in three-dimensional evaluations when it comes to planning reconstructive surgery and is commonly used to guide biopsy. Moreover, CT scans can be very useful in osteolytic lesions when the fracture risk must be evaluated. Another case, right femur osteosarcoma. I'm going to pass this. This is the osteosarcoma lesion. You see it's a lytic blastic lesion involving the metaphysis, breaking through the cortex. There is a soft tissue mass, of course, with this lesion. You can see it from behind. You can see this on these radio imaging. And when malignancy is suspected routinely, you should do a chest CT scan, and this is mandatory out in lung metastasis. MRIs is the modality of choice for local assessment and staging of a malignant bone tumor. It is recommended to have this study performed by a radiologist experienced in malignant bone tumors and in the institution where the patient will have treatment. MRI is much more sensitive than conventional radiographs. Lytic bone lesions can be seen on plain radiographs only when 30 to 50% of mineral is lost. You have to keep this in mind. This is a question we love to ask. And if a patient continues to have symptoms and radiographs do not show any abnormality, MRI is the preferred modality to assess bone marrow, soft tissue mass, and the involvement of neurovascular structures and adjacent joints. Okay, and these are multiple cases I'm going to show you. Just 1 second. I'm giving a lecture. Okay, so let us speak about several cases. This is an osteosarcoma of the proximal tibia with extension into soft tissues. You have to know how to evaluate them. Start by plain X-ray. You decide, you do you want to do a PET scan or scintigraphy to see if there's distant metastasis. You have to do a CT scan of the lungs routinely on these tumors, okay? And MRI will tell you a lot about the soft tissues, the extension or skip areas, or satellite lesions. But a CT scan is important. It describes the lesion locally. Plain X-rays, you can make a diagnosis, but when you have lytic lesions, the X-ray will not be apparent unless 30 to 50% has been destroyed. Okay, so this is what I'm trying to tell you. PET scans, when we use fluorodeoxyglucose, it tells us about if there's a tumor, the activity of the tumor. It will tell us more about lung infiltrates, lymph nodes, or distant metastasis, and skip metastasis. So this is what I would like to mention about these tumors. Laboratory tests, you have to do a full workup on these patients because there are many endocrine problems that you can confuse with tumors. Don't forget this, please. Let me see over here what we have. Rand et al. Concluded that high serum alkaline phosphatase, when it's high in osteosarcoma, it indicates a bad prognosis. LDH, when high in Ewing sarcoma, it again indicates bad prognosis. So you have to, the biopsy, we spoke about it in the past, but you have to know how to take the biopsy, where to take the biopsy. The biopsy should always be taken in an aggressive tumor, always at the periphery, okay? And you have to take the opinion of the radiologist, the pathologist, and yourself. The biopsy is preferably done in the center where you're going to do the limb-sparing procedure. Okay, so this is something I would like to mention. Let me see if this, I have a lot more, but I don't think I can finish. You have to stage these tumors. You have to know that anything staging system. This. You don't have to know anything other than this. You have to know this. Okay? Study.
دكتور جون اخر يعني ما بيتحرك السلايدات، سلايد واقف.
الآن بقول لك ليه؟ ما بيتحرك من عندكم؟
لا.
هلا عم بيتحرك؟
لا، نفس لايتك والليجنز اللي هو
في حدا مفيت لي، في حدا مفيت لي حاطط your screen sharing is paused. ليه هالزعرنة؟
والله
please, Dr. Johnny, the screen was for me about 2 minutes was black. 2 minutes was black. 2 minutes ago, the screen was a black. There's no slide at all.
عم بقول لك ايه يعني
دكتور ممكن تعيد من جديد يعني ما يعني من عندنا ما حدا احنا بالهذه، لكن جديد ثاني
هيدي الثاني مره بيعملوا لي بوز.
ايوه
لا ليك رح بشيلها هاي وارجع اعمل شيرنج. منيحة هلا؟ شايفها؟
ايوه شايفينها. انت مشيت عليها على السلايد هذا عدة سلايدات بعد.
هلا رح بغير بيرجعوا بيشيلوا لي اياه، يعني زعرني كثير. host disabled participant screen sharing. من عندكم قايليني حاطين خالد هلا شايفه؟
ايوه هلا
بيرجعوا بيحطوا لي اياه. You are sharing screen. اوكي حتى نشوف. ماشي هلا؟
ماشي ايوه.
منيح نشكر الله. حتى نشوف وين وصلنا. هلا رح احكي. I strongly insist that you use the King staging system. وبقول لكل إنسان يحطها ويتمرن عليها. This will let you judge how to operate, where to operate, how much to remove. Okay? So this is something which is important. Now, هلا رح بيجي شغلة فوت ليا. We mentioned the highlights about osteosarcoma. رح بجرب خلص osteosarcoma, Ewing sarcoma, and then end my lecture. لأن ما بقى عندي صوت. Osteosarcoma classically may occur in any part of the bone, but the most common is a classic intramedullary osteosarcoma. This is the most common, and the male to the female ratio is 1.5 to 1. We mentioned previously that it's the most common malignant bone tumor in children. In the United States, there are 1,000 to 1,500 new cases in the United States. It is bimodal in age, but we are concerned about children. It is the most common to occur in the second decade of life. This is the most common primary malignant tumor of bone. Of course, later on, there is a peak in the sixth decade, and I recall telling you once upon a time that it occurs secondary to Paget's, radiation therapy, radiation, or any scar. But this is not our concern today. The etiology, we all know that it's associated with retinoblastoma, which is a tumor suppression gene. There is an increased incidence in patients with P53 mutations, Leaf-Romani, as I spoken, Paget's disease in the elderly, prior radiation, Rossman-Thompson syndrome, and retinoblastoma. We know that MDM2 and HER2 new c-MYC and c-FOS are oncogenes overexpressed in osteosarcoma. They usually have intermittent pain, and it's progressing to constant, and it occurs at rest, night, pain, and this is not relieved by any form of medication. Swelling, decreased range of motion, limp, and weakness, depending on the location of the lesion, exist. Often, they present after an injury or sporting activity, and they think that the sports is the cause. It's coincident with the age group. No causality known to trauma. We don't. But the family says, يأكل ضربي. يمكن هي السبب. Most commonly noted in the metastasis of distal femur, proximal tibia, proximal humerus, and pelvis. 10% of patients present with a pathologic fracture. Osteosarcomas have a mixed appearance with bone destruction and bone formation. In skeletally immature patients, most do not extend past the epiphyseal plate. Usually the epiphyseal plate is a block. It prevents it. It occurs in the metaphysis, but does not extend into the secondary epiphyseal ossification center. Most have cortical destruction, a soft tissue mass with adjacent Codman triangle, normal reactive bone near tumor. Classic osteosarcomas originate in the medullary canal, as I mentioned. Let us go into a case. Patient, 15 years old male, reveals an osteosarcoma of the distal femur. AP and lateral reveals bone formation and a soft tissue mass after 3 cycles of chemotherapy. Axial MRI reveals a soft tissue mass abutting on the posterior neurovascular bundle. You see over here, I want to show you. The lesion is located in the metaphysis. You see there's an elevation of the periosteum here, and therefore this is a Codman's triangle. There's a soft tissue mass. It is blastic mainly. There are some lytic areas, but mainly blastic. This is an MRI showing you the soft tissue content. And this is the lesion while doing a limb sparing procedure. You see it has penetrated the bone over here. Over here, you have an elevation of the periosteum, and this is called Codman's triangle. These are the tumors, the osteoids surrounded by irregular osteoblasts, which are aggressive. You can see them over here. They have multiple sizes. They are hyperchromatic. And this is tumor osteoid. This patient also has another patient, I will show it to you now, with a lesion occurring in the metaphysis with deformity. This was an osteosarcoma. Likewise, over here showing you the soft tissue content. And the differential diagnosis, we have mentioned it. Technetium scan, bone scan can identify skipped lesions. MRI delineates extent of the marrow involvement and also tells us about skipped lesions. I want to see if in this we have a skipped lesion. Let me see. No, not here. I will see it on another view. And that's it. Now, we are using a combination of drugs for osteosarcoma, but you have to know and study this table. This table is important to know the side effects of each of the drugs we use for osteosarcoma. Okay, radiation is no longer used. Okay, and local recurrence following limb sparing is 5%, but you have to study your patient. Well, if you want to do a limb sparing, you have to think that you have to give this patient a useful extremity to be able to walk on, to bear weight on. So this is very important. Okay, we spoke about elevated dehydrogenase and alkaline phosphatase. These indicate a bad prognosis. Okay, the 5-year survival is 65 to 70%. The 5-year survival in lesions of the pelvic is only 25%. Okay, so I want to go, there are multiple types, but we don't see these often in children. We don't see a parosteal osteosarcoma. we don't see a periosteal osteosarcoma. The main osteosarcoma that we see in children is the medullary. So we're not to discuss these now. Okay, these we don't have to discuss them. Only this, telangiectatic osteosarcoma, these lesions. I want to get this out of. It's rare variant. You see, it's a purely lytic lesion. You have to distinguish this from a aneurysmal bone cyst, and this is a very aggressive form. They have present as pathologic fracture. So it's a purely lytic. It can be associated with an aneurysmal bone cyst, and you have on MRI fluid levels. This is one at an telangiectatic. These are the pathology, and this patient had a limb spare procedure. So Ewing sarcoma, I want to just show you, it's a round cell producing tumor. If you look at the innominate bones here, you see this is more dense, okay? If you're not experienced with it, you might tell the family, oh, I don't see anything. But there is a lot to be seen. And this shows you with scintigraphy. This is the lesion of how big it was. So you have to pay attention. It's a round cell. It involves mainly the diaphysis, but it involves flat bones also. Likewise over here. And you see, look at the pathology. I like you to know about it. These, what we hear is a pseudo-rosette. A pseudo-rosette is a number of cells, round cells, okay, round cells, that surround a zone of necrosis. The tumor grows on the outskirts, not centrally. And there is a 1122 translocation. And look at over here. This shows you the rosettes. And you should distinguish this from a neuroblastoma. Treatment combined chemotherapy, and the 5-year survival has gone up between 60 and 70%. And now I'll tell you, thank you very much. Next time, we'll go into something very different. Orthopedic related syndromes. يا عمي إن شاء الله ما زهقتكم.
Thank you very much دكتور جون. لا بالعكس والله الشباب مرتاحين يعني ومبسوطين معانا الحضور كويس يعني حوالي 70 نير يعني 70 بيرسون وإن شاء الله
خالد أنا برضه شيء مش راح أطولك كثير لأن زلمة ما عم بقدر أحكي بقى.
لا براحتك يعني تشتي مثلا تكملها مرة ثانية عادي تشتي.
أنا فكري إنه عاملها وسط بس كنت بدي أخلص كم شغلة. بدي شيل التيومرز على الجنب وارجع فوت بكولد اورثوبيدكس. هيدي غايتي. اوكي ورح نقشع بعد خالد ب7 الشهر بالاردن. مزبوط؟
ايوه انت بتكون موجود صح؟
ايه يلا
نشوفك.
اوكي حبيبي يلا ثانك يو.
Thank you حكيم. Thank you so much.